is to be felt. No, there is no expectation.
Really, I thought you want to talk on it.
No.
The only thing is that some people have their flights in the evening, so I thought that I am very sorry to disturb the rhythm, but I thought that there are a lot of people who are waiting to listen to Arti and Mani, and they have both made excellent presentation. I'll request Dr. Arti Behl to talk on communication skills. And communication is an important aspect which is not taught to us in any curriculum. So I think this is what we need to understand. So we have three series now. We have communication skills with approach to obesity clinically as well as from the psychological perspective. And thereafter we will have endocrine cases and endocrine realities being discussed by Dr. Arti Behl. And I join him in terms of discussing endocrine and stress related associations with mind-body medicine. So over to you, Arti.
Good morning, everyone. After the long rhythm of music, without saying anything, I would want all of you to talk in my communication workshop. I'll start with an example of how a communication should not be done. And this example is so etched in my mind that I give it as an example each time in the workshop. There was this patient who had dwarfism, not exactly dwarfism, but he was short stature. And he came to Anish for some checkup, and Anish got his blood tests and everything done. And we were to leave that day a little early. We were stepping down from the staircase, and this guy must be all of around 5 feet 2 inches, already a 20-year-old. So Anish just looked at his reports, and while going down the staircase itself, looked down upon him and said, "Ab aapki height aur nahi badh sakti." I think it's the finest example of how a doctor should not be communicating. So when I asked him, I said, "Did you do the right thing?" He just looked at me and he said, "Yes, I had to tell him that." So is it only what we need to tell a person, or is there something else along with it? I would like all your inputs into it. Please come on. Without taking too much of time. So what else is required? Yes? There's a mic there.
Yeah, so I'll just say 10 seconds that when doctors tell something to the patient, it should be जोर का झटका धीरे से लगे.
Absolutely. So probably the way you put it across. So even if it's the worst of information, the way we need to put it across to any person has to be done with an empathetic manner. So you don't need to sympathize with a person. Like I always say, it's not that, oh, poor thing, you got this or that, but just understand, if you were to be in the shoes of the person, how would you want a doctor to convey the same information to you? So the process of curing a patient requires a holistic approach. That is what we all are discussing, all these days in the four-day workshop. And it involves considerations besides the disease process, the diagnosis, and the treatment process and everything else. And studies have shown that communication skills, if they are good, it improves the patient's compliance and overall satisfaction. Have you all ever had a bad experience with a doctor? I want an example. Yes. I want an example. Yeah. Yes, please tell me.
Hello. Yeah, this was again with my gynecologist. So she kept on telling me your weight is not gaining. So I told her, I'm not dietitians are eating properly. And she gave her own piece of advice. So then till date, going back to her is always frightening for me. Should I really go back to her again? So maybe she should have conveyed to me in a good manner. But she's a senior most doctor. So I respect her what she
about the experience.
Experience.
She just told you to put on weight, right? I mean,
No, she was rude. She was rude. So she was a serious most doctor over there. And during the end of the period also, she was very strict. But I became calm. I had to go with the flow. So even till now, even my husband says, if you're not fit, do you want to go back to the doctor again? I said, no, I don't want. I don't want to go back to her again. So. And still that fear is still there. Never been worried about any doctors, but specifically this is still there.
It remains with us for a very, very long time, and we don't want to re-experience it. So patient listening, empathy, and paying attention to the Paraverbal, non-verbal. What is paraverbal and non-verbal? Any idea?
The tone in which you talk.
The tone in which
body
you talk.
language.
Yes.
When you look down and you look up, how you
Yes.
speak.
So there are examples of doctors who do convey things what they want to convey to the patient, but they don't look into the eye of the patient. They're not empathetic enough. They're looking somewhere else. They're looking at their phones and talking. They're not looking involved in the entire conversation, which makes the patient feel very, very neglected. Obviously, put yourself in the patient's shoes and then think about it. So, what are the benefits of good communication? Over here, we all have been doing it in the past 4 days. What are the benefits?
Better bonding.
Better bonding, definitely. Okay, so it brings about a trustworthy relationship between your doctor and a patient. The diagnostic capability of a doctor goes up because if you're talking, I'm not saying talking lengthy, but talking making sense. Obviously, you're eliciting the kind of history that you need to get from a patient. So you're able to give him a better treatment, a better management plan. It's also useful in managing very difficult clinical situations, okay, especially in critical areas where there are emotional outbursts. So we come across so many incidents of doctors being beaten up or the hospitals being shattered down. So why does that happen? Any ideas? Any of you working in the critical care? No? Okay. So what happens over there is that the doctor tries to convey whatever is there, whatever is the condition of the patient, but it's not getting into the attender's head. So it's either conveyed in a manner in which the patient attenders don't understand, or it's conveyed in a very hurried manner, or in a manner in which the attenders don't feel satisfied with. So there's something wrong with the communication skill of the doctor. It's also been shown to decrease the work stress of the doctor and to increase job satisfaction. Just remember, one day if we don't talk well to a patient or we shout at a patient and go back home, do we feel happy that day? None of us do. Okay, and remember the days when you've gone on smoothly, okay, not too great conversation with people, but then it's gone on smoothly with patients. Don't you feel satisfied that day? So all of us have that satisfaction if we communicate well. It also improves the patient satisfaction and definitely it improves the compliance in these cases. So verbal is the verbal component, that is what we speak or what we have to utter, what all we have to convey to the patient. The non-verbal is your body language. What all are the negative things in the body language that we don't need to do? I want all of you to interact. Yeah.
Closed up posture, leaning away.
Yes. Okay, closed up posture, so sitting like this or leaning away or looking out. What else?
Not looking at the patient.
Not looking at the patient.
Eye contact.
No eye contact.
No touch.
No touch. Okay, touch can be a little touchy. I come to that. Yeah. Yeah. Looking into your phones, right? These days, all of us are sitting in front of our laptops, okay, typing our EMR sheets. How do we communicate with the patient then?
There appears to be a barrier.
Absolutely. So in the middle, at least, I don't know with all your ergonomics, it's very difficult for us to be keeping the laptop in front of us and at the same time looking at the patient and discussing the details or typing in the history. So I would rather keep the laptop at a distance away or type my sheets later, which then again becomes a difficult venture. But that comes in our way these days. The paraverbal component includes the tone, pitch, pacing and volume of the voice. Like she said just now, the gynecologist said something, but it was very rude. Right? So probably the tone in which the doctor spoke to her was not too good. So we have to keep watch on the tone, the pitch, the way we communicate. So what are the barriers in communication? One is lack of insight due to inadequate knowledge and skills about communication itself. So we think that, okay, we don't need to be skilled enough. And we do come across doctors. All of us have, right? We all have had experiences with doctors who have not been able to communicate the right kind of information to us in a right manner. So that becomes a barrier in communication. The other is when doctors may not give enough heed to the importance of keeping patients adequately informed. Now we have a father-like, a paternalistic attitude towards patients, especially, in India. We think that, what we are doing for the patient is always right. These days, it's a patient-centered approach. So we should ask the patient, okay, these are the options. This is the buffet lying in front of you. This is the menu. Okay, what do you want to choose out of it? Even if it's the worst choice, you can only make him understand or her understand the advantages and disadvantages of that. You can't do anything beyond that, can you? So if the patient feels that, okay, that is the best treatment option available for him or her, let them go ahead with it. So let us stop having this kind of a paternalistic attitude towards the patient. All we can do is explain the pros and cons of the treatment. The non-verbal components of communication are frequently neglected. We don't look up, especially like I said, typing. A phone call comes, we are more involved over there, and then we keep instructing them that look at this sheet, okay, go out, tell the sister to come in at the same time. So many things go on at the same time parallelly, and here we are actually sitting in front of the patient, doing our job, thinking we are doing it well, and all we have to do is take care of the patient, which we are not. So I think we all have to be a little mindful about how we go about conveying or talking to a patient or to the patient's attenders on a day-to-day basis. Language barrier is very important. I have experienced it, all from the north. I went suddenly to Tamil Nadu to do my MBBS, and then I came to Karnataka to do my MD, and now I've been practicing over there. So I have experienced all of it. The best thing is to first tell the patient that you don't know the language very well. However, you will try to understand or get an interpreter. So language is a barrier. Lack of adequate knowledge about the disease or the treatment options. So if I don't know about the options that are available for the diagnosis or the treatment plan, how will I be able to convey it to the patient? So I think the best thing would be, I'm not the right person, but I'll refer you to the right person and send him away. Human factors like stress, tiredness, or lack of time. Do we work well when we are stressed? We want to just run away from that place and leave our clinics and just go back home or relax. So I think identify that stress level in you. If you think that you're feeling very stressed out, give up for that day. Call it a day and say that I can't see any more patients today. Or if today you feel that you have enough of work at hand in the evening time, say that you'll take in only 10 patients on that particular day. So don't try to be very greedy in that context. How do we improve on the listening skills? Any idea? Any of you? All of us dealing with,
Talk less.
Talk less, very good. Yeah. So it's not a lecture from your side, you have to listen to the patient. But if the patient goes on and on for a very long time, then?
The label is rude on Google reviews.
Yes. So how do we stop those things?
Actually, we can just redirect them. Right. Asking right question is the good way of listening.
Absolutely.
My lessons
Yeah.
are for 1 hour of appointment, and especially women patients, they talk a lot. They want to share all the information. But if you will, channelize what you want them to tell, it works better.
It works. So how do you channelize that?
Asking right questions.
Open-ended questions, yes, but you keep getting answers, and open-ended means there's a lot of information over there. The patient doesn't know whether it's right or wrong, I need to convey to the doctor or not, is it important for me or not? The patient doesn't know. You have to choose and pick up. So how do you do that? Yes?
Just doing a quick analysis, what type of personality they are, whether they're
That will
talking
take very, very long. So they will start talking. Okay.
so with that we know if someone who's talking too much, we know they talk a lot. So cut
how do you
short.
channelize that?
Bring them to that point of discussion.
Discussion.
How do you do that?
Ask
How do you do
specific
that?
questions. Targeted questions.
Okay, specific, but then you don't know whether you'll get adequate history or not in that case.
So first session we take the history. So we just allow them to talk a bit. The first session is entirely about them, so let them talk. So more or less we gather a lot of information.
What if the patient keeps on telling you the same thing again and again?
Have an assistant.
If you don't have one.
You have to summarize that you listen.
Absolutely.
and then
Absolutely
ask
correct.
Next question.
So just paraphrase it for the patient. Say that, I have understood that you told me that this is a difficult situation for you, and I have understood. So can we move ahead? Okay. Do not sound rude at that time and say that, I've heard you. Come on, next. Okay, I'm sounding a little rude right now because I have to finish off my session in time. So you paraphrase it for the patient. Say that, I understand that those 3 months were a very difficult time for you, and you would not want that to come back. So you want methods of how to prevent those 3 months again coming back to you or whatever. So, and also, when you're winding up a session, just summarize the whole thing and tell the patient that this is what I have understood out of the whole thing, and is there anything else that you would want to add on? Before leaving the chamber, most of our patients will ask us, everything is normal now. How do you deal with that? What do you tell them? Everything will be normal?
Let's hope for the best, yeah.
Okay, yeah, that is one method. Anything else?
There's a definite potential to get better.
There's a definite potential to get better. Yes, if you put in efforts. Yes. Anything else?
Work together towards your goal.
Yes. Okay. So never be very, very pessimistic when they are going out, and don't say that it all depends on you, or things like you will not improve if you keep not exercising or not doing things. Just let them be going out with a positive note. Also realizing that everything doesn't depend on the doctor. I have to do my bit at the same time. Many a times attenders would come and talk to you for a very, very critical patient, and then while leaving they'll ask, "Doctor, everything is normal now." How do you deal with them?
What we can do is we can actually give them what is positive about you and what are the things which need some work on it. And then, as she mentioned, we will work as a team. So your efforts are equally important as mine. So it's not like complete burden on you.
Also for depending on the seriousness of the situation, just let them realize that the patient is not doing too well, or doing better than yesterday, but I cannot really give you any kind of too much of positivity or too much of guarantee in it. We'll see how one day goes at a time. So slowly release the information to them, but never keep them or just to keep them happy, saying things like oh, he'll be all right, she'll be fine, or by within 1 week she should be okay. If you're not sure within your head, do not give those false assurances to any of the patients. So
इससे क्या होगा मैडम?
किससे
ऐसा करने से क्या होगा?
क्या करने से?
False assurance.
False assurance. So if the patient doesn't improve,
We'll come and catch you. Now,
They lose trust.
and it's an era of medical legal issues. Very
see, when you know that you're giving a false assurance to a patient, you're yourself not sure that the patient is going to get better. Now, a patient of schizophrenia who comes to me will ask me, the attenders will ask me, कि ऐसा अभी अगली बार तो नहीं होगा. How can I say that nahi hoga? When I know that it is a recurring illness, it is bound to come back, it will come back. How do I tell them that nahi hoga? Isn't it wrong on my part ethically as well as a doctor? You're here to give them information. You're not here to, make them feel good. They don't feel good with you, they'll go to another doctor, it's okay. But you cannot go wrong in your own ethics. So, probably.
I have a question. Even if it's a schizophrenic patient, you can show him a brighter picture that you're going to become this, and you can paint that picture in front of him so he feels better.
Definitely. Like we said, let them leave with a positive assurance, but don't give them false reassurances that you're going to be absolutely fine. Right? Now, show interest in what the patient is saying with your mannerism, body language, and active involvement in leading towards the patient. So whenever the patient is talking, at least nod your head or look at them into the eye or lean forward, or just be a little more involved, or just do a hum, ha, or things like that, or okay, and then go ahead and things. Mannerism like patting the shoulder, holding hands, or nodding may convince the patient that you care, but the context should be right in this manner. Like I said, please, in this era, okay, I think the men folk have to be a little more careful about these things. It's fine for us, okay? Especially, when you close doors and, you have a female patient who's crying very badly in front of you, and then you go and try to pat the shoulder or hold her hand. You don't know in what context she'll go and put it out across to the world. So you have to be very careful about this situation. Also be careful not to interrupt him or her when he's expressing something that is actually important. But you can paraphrase it. If the patient is going on and on about it, okay, you can always say that I understand this is a difficult situation for you. I'll talk about it at length later on. Can we go ahead? Okay, so it doesn't sound rude when you're trying to interrupt the patient at that time, but it can be done in these methods. While concluding, one must ask the patient if he would like to add something more. Usually they don't have anything to add something more, but you can always let them know that, okay, you can write it down next time when you're coming, or whenever you're coming next, we can discuss the other things that you have left out. So it's not that you're giving an impression to the patient that, this is all done and I'll not talk with you any other time, or you're done with your conversation, now you have to listen to my conversation henceforth. So you can always give them the hope that, yes, when you come back next, you're going to put across your other points that you have forgotten, and for better, improvement in your communication with me, you can probably jot it down or note it down in your phone when you're coming next to meet me. Also, when they're going away, they'll again ask the same question, or they'll come back to the same topic, and you can again, rephrase it and say that, yes, I've understood that problem, we'll address it slowly. So don't ever interrupt them or say that, you're done with it and I have the next patient waiting, please get out of my OPD. How do you all deal with too many patients in a day?
I think you have to tell them that the next patient is waiting.
Yes, yes.
I think you have to tell them.
Can that be done in a more polite manner?
Sometimes you can make your paramedical staff come
Come.
and tell you.
Yes.
I'm sure physicians and endocrinologists cannot handle the load. And it's not a question of greediness. We don't want to work so much.
Yeah.
There is no end to the limit that you can handle. And I think that you all have seen me for 4 days, but my reviews on Google will be most rude,
Yes,
most arrogant, and you can't control it. You understand? So I don't know how to do it.
I
You
don't
can
know,
teach us.
Vaishali, just to lighten the mood, we three of us were in one common hospital. I don't know what is the training to their staff, but training in our department is ki the average patient time, in my room is supposed to be like 6 to 8 minutes. And you could also wonder that how can a psychiatric or neuropsychiatric consultation can at all happen. So at the 6th or 7th minute, the hospital is so professionally trained, those people outside the reception person actually opens the door and peeps in. So I don't know whether your department has any different training or her department has any different
For me, I
training.
think she's my assistant. She bears the brunt of the whole rudeness, I would say, and she does my.
So what we can do is, for someday, like we are saying यहाँ करने का academic exchange, so we can send our reception staff to train your reception staff. Art of doing इसको कैसे?
I think that's a good idea.
I think sometimes patients do get
Then what happens is that lot of patients उनको एक दो बार आते हैं उनको समझ में आ जाता है कि इधर तो maximum time you have to spend actually कि वो नीचे से पास लेके ऊपर आना पार्किंग करना और इधर का तो एकदम वो फिर पूछते हैं कि आपका क्लिनिक वगैरह तो मैं उनको बोलता हूँ देख भाई ऐसा है कैच ऐसा है कि क्लिनिक में वक्त तो मैं ज्यादा दे सकता हूँ पर क्लिनिक की तरफ वो अपॉइंटमेंट बिकॉज़ माय क्लिनिक इज लाइक अ कोर्ट वहां पे मैं अपॉइंटमेंट डेट आगे आगे बढ़ाते रहूंगा एज पर मेरा कन्वीनियंस सो वेदर यू आर इंटरेस्टेड टू मीट मी एट ऑल फॉर 6 minutes on predicted days or whether you can have my 1 hour but when that 1 hour will be ranging from 1 week to 1 year is not guaranteed. So yes, but she is absolutely right that people do have these kind of and the real issue therefore is absolutely that in the Indian context and particularly in a very busy I mean lot of people here are physicians and endocrine people and I think they do have to handle enormous to say the least means
I remember a few.
How do you tell them?
Okay. I think they've understood me on the reviews.
Suppose a new patient walks in and he's taking too much of your time.
I think my body language shows. I start looking at
So instead of that, you can actually be very direct with the patient and say that.
that directness goes into rudeness. So that is a.
So that rudeness can be changed a bit, and the patient can be told that look, there are a few patients waiting outside after you. So I can spend this much of time today. However, we can sort out your issues later on at a later date. I have taken care of the important things today.
I'll share you one experience. I do a World Diabetes Day every year, and we have around 1,000 patients coming to the hospital on that day. And usually the patients, they told me this time, we thought that you could never laugh. We have never seen you smile. So the reason is not that I don't want to. The reason is that I can't afford to. If I smile at everybody and laugh at everybody, that person is going to take 1 extra minute, which is going to hamper my next patient who needs my attention. So I think that's an important skill that you need to teach us actually.
Then you have something to add.
So, in the first 1 or 2 minutes, we can judge whether this fellow is going to sort of go on and on, or he is going to be prepared. So, if I sense that the patient is going to go on and on, I set the agenda. I say, why are you here? You know, most patients will tell 2-3 responses. One is that I am upset. Second is I don't know what is happening to me or something. Then if he's upset, then I will set my agenda that I have to give just some emotional first aid to this person and send him off. Diagnosis is not that important. Okay, and rule out the risk factors. He's not suicidal, he's not homicidal and all those things. So it takes about 20 minutes. If he says, I want to, this thing, get a diagnosis, I want to know what is happening and all that, then I will tell him, okay, then I'll ask you certain specific questions because I don't need to know the whole story to make a diagnosis. Okay, so you start, but I will be guiding your this thing. And when I get to my diagnosis, I tell the patient. So I have got the idea what's happening to you. This is how we'll work. Do this and come back. I keep it very agenda and this thing oriented.
We are really running with, having a race with time and the numbers. So whenever we are in those walk-in OPDs, we really can't do real justice to all of our patients. So sometimes we have to give some more time when they are critical cases with big number of files they are coming up and chronic cases. We have to give some more time to them. And there are some very subtle cases or very routine follow-up, we have to really nip out them in 2 minutes. But sometimes it hurts. That patient doesn't take it that way. Although he is a regular patient, sometimes he can take it other way. That doctor is not listening to me. Say I'm such a old patient of doctor. That's all. But generally, I see to it that I can gauge that I allow him to talk for a minute that day. That doctor was telling 1 minute test. So I just allow them. I get to know how much the patient is able to tell his or her complaints well. If he's in the right track and telling me, I just go on listening. But if I feel he's not really going haywire, then I direct him. I make directed questions and then he answers and goes on. And generally, I make a rule that never get irritated. Whatever the patient says or whatever the patient, they are already frustrated. They are already in a very bad mood. So if I also get irritated and start scolding at them, it really becomes a mess. And then every patient and my temper goes on and on and on. So I have made it a point, whatever happens, whatever the patient scolds or whatever he irritates me, I'm not going to scold at any moment of time and get irritated. I just then afterwards, when he crosses my limit, if at all, and I said, sorry sir, I know this much and I've told you this much, and next visit probably you come with an appointment and I'll sort out your more issues.
Right now, Arti is going to scold us.
Yeah, so like what Vani was saying is very important. We need to rule out the main features, okay, for the first visit or if the patient is going on and on speaking about things. The rest of the things probably, we can actually relegate to the later on part and we can tell him that, I haven't yet reached a diagnosis with you, but I think this is important for you right now. You get these tests done or, I'll see you again after a week's time or whatever, and then we'll take it forward. But ruling out the most important things, the critical things is, I think, critical for for that particular visit. Yeah, you had something to say.
Hello, yeah. So this is what I do as a dietitian in private practice. Learn this from somewhere. So rightly said, first 2 minutes I'll allow them to talk. I know what the case is. Then from that I'll analyze the behavior of stage. Are they going to change or not? Which stage they are in? They are in the contemplation stage or the prepared stage, or they are in the action stage, or they are in the maintenance stage. So based on that stage, where they are, which level they are, I'll completely change the top of the assessment. So some assessment may go for 45 minutes, some may even get done in 15 minutes. So okay, this is what their level is. That way it helps. And along with that, all the empathy and listening skills will add on. So
and
that
sometimes when we go on
helps.
and on, let the patient talk, they take us also for granted. So we have to have a particular time slot but then be polite to them when you want to end it.
And I just want to ask that what about the multi-team approach? Those who are having 100 patients, can't they have a kind of delegation of work?
They can.
Yes.
They can.
तो ये जो
Definitely.
whole load है
Multi-team approach you can.
Multi-team approach कितना है अपने यहाँ पे?
Very little. Very little.
We are
I
not
agree.
using the potential of other people who can help you out.
Absolutely.
I have a
Yes,
comment. I have a big team with me.
Yeah.
Okay, but the problem is
Yes.
patients don't want. Now, for example, I have a dedicated dietitian only for my patients.
Yes.
Though I work in Apollo, but I have a single dietitian who works only for
Yes.
my patients. In spite of patients having spent time, usually I make a rule that the new patients meet the dietitian and then come and meet me. After that, 9 out of 10 patients want me to tell diet again. They are not satisfied. They said, sir, आप हमको बताओ.
Sir, so
I will tell them that okay, you met a dietitian, she has told you about it. You follow those diet. नहीं sir, आप हमको बताओ. And again, you know, they'll have a lot of questions. क्या मैं ये पी सकता हूँ? क्या मैं खा सकता हूँ? All those kind of things. So what happens is, we may want to do something, but our patient should be ready for that. The problem in India is patients, when they come to meet a doctor, they want to meet only the main doctor. They're not happy with the ancillaries or the paramedical staff or the assistant doctor. I was just giving an example to Arti the other day. I was doing rounds. Just before me, then a patient told me, sir, Dr. Vadwa has not come and seen. Dr. Vadwa is a gastroenterologist, he was very famous in our hospital. But his assistant, who himself is a DM, okay, he has come and seen the patient and gone, but this person did not want him. He wanted only Dr. Vadwa to see. So the problem is from a patient's perspective also. So I think we may try to impose certain things. The patient should be ready for those things. That's what I
You're talking about diet. My patients want me to tell them the directions to the clinic, give appointment, confirm appointment, everything. Even if my receptionist has told them that come on a certain day, again they will ask me, give appointment. And they will also scold me. 2 minute address समझाने से आपको क्या होता है?
You should tell दो मिनट लगा करके मेरा
totally agree. I totally agree.
This is
Patient's
where the
view
food
also.
reviews come.
Patient's view also. But still, as a doctor or as a
No,
team,
we have to
medical
put our
team,
foot down.
what we or whether it is necessary for us to build up a common language which a dietitian and a doctor, both of them they understand, so that the patient will come to know कि अरे dietitian भी वही बोल रही है जो डॉक्टर बोल रहा था.
So one of the things I have
नहीं तो dietitian कुछ अलग बोलते हैं, डॉक्टर कुछ अलग बोलते हैं, वो बहुत ज़्यादा होता है. So are we really training ourselves in a multidisciplinary mode or not? That is the issue. But in no medical college it has been taught that all the clinical rounds or everything should be taken by everyone who is going to assist that patient. Dietitian ने भी होना चाहिए round पे, सब ने होना चाहिए round.
I think we are all following it in psychiatry, at least, during our PG days, we all always used to have a PG consultant, clinical psychologist, psychiatrist, social worker with a psychiatric nurse.
में कहीं नहीं होता है.
Actually मैं एक ऐड करूँ, डॉक्टर लीना हैज़ अ रियली वंडरफुल पॉइंट. मैं सेंट फ्रांसिस हॉस्पिटल यूएस में काम करती थी. So what there was, the first time every discipline member will see the patient, but before second appointment they all have to discuss that case.
Exactly.
Everyone will be on the same page. Then next communication will be go to the patient. So treatment approach was very different, and that's really wonderful approach. We should be actually.
मैडम क्योंकि अपन अपना rounds कम नहीं करना चाहते हैं.
And on rounds, if all of us are going together, I think all of us will be at the same page.
Expert doctor should be at top. और वो पूरा टीम लीड करे कि उनका हर डाइटिशियन, हर एक्सरसाइज थेरेपिस्ट जो भी है उस टीम में, they are under that doctor and the doctor should know कि ये क्या बोल रहे हैं.
Absolutely. Totally agree with that point, and that's how we are going to reduce our burden probably later on with the kind of population that we have in our country. Definitely. So we are all following it. I don't know, we were following it in psychiatry all these days. I think it should percolate down to other specialities. So before starting any interview, respect the patient's confidentiality and maintain privacy. All the time it's not possible for us. The patient himself may come and start asking us details about his diagnosis or his treatment at times. I think we need to tell the patient that, I'm available to you only inside my OPD and nowhere else. A car parking area or somewhere where you meet a patient in the mall is not the right place to discuss about his or her diagnosis or treatment. You can be polite and tell them that, let's discuss it when you come to us later on or in my OPD. Be the first one to greet the patient. Always introduce yourself whenever feasible, especially when we go on rounds. Most of us don't wear our aprons these days. Most of us are not carrying our stethoscopes these days. So how would the patient know whether we are doctors at all? So just go and say that, I'm Dr. So-and-so, from this specialty, and your main consultant, whoever, whatever the name is, this person has asked me to come and meet you. I think it starts off a conversation in a very, very positive manner rather than just going and, acting a little paternalistic and saying that, okay, what is your problem? All of us would be feeling disturbed, by just an unknown person coming and standing in front of us and saying, what's wrong with you, kind of a question. So be the first one to greet the patient. Address the patient by his or her name whenever it's required, especially when, even if it's a new patient, you can ask, okay, you're Kamla, or, you're so-and-so. Even if you have your old patients coming in, you know them, obviously, you have their name on the file, even if you don't remember them. So you can always ask them that, how have you been doing, or what are you doing? Establish eye contact and maintain it at reasonable intervals. So, like I said, with our new system of entering everything into the computer, it may not be possible for us to be maintaining eye contact all the time, but at reasonable intervals, you can always keep looking at the patient and keep inquiring, okay, you said this, and then as if you're entering something over there, look again at your screen and then look back. Put the patient at ease. Many patients are very nervous, especially many of them who come to psychiatry, at least, they hate us. They don't want to come to us. So the first thing, sometimes actually it's so disappointing, they'll come and tell us that, doctor, I never wanted to land up in a psychiatrist's OPD. I'm sure none of you face it, but we all face it every day. We don't show a reaction to it because we know that, how difficult it is for a patient to be labeled with all the stigma of psychiatry and then come to our OPD. So we just ask them, first comforting questions. So just to settle them down, if it's an old patient who's looking very jittery, so we just said that, have you had your breakfast today morning? Or who came along with you? Some kind of a neutral conversation just to put the patient at ease. Many times there are new patients who don't know how to start a conversation with you. So they don't know. They just say that, doctor, I don't know where to start from. So you can actually say that, okay, is it okay if I start asking you questions? You can just start about their social background and, what they've studied and whoever's there in their family and things like that, just to put them at ease. Sometimes we have to deal with long pauses. So you ask the patient something and they don't get back to you very easily. Can you understand the pain in the patient's mind that's running and that's inhibiting her or him to get across to you?
Yes.
See, for us, it's like our OPD, which is so many patients waiting outside. But imagine this person. If you can change the life of that person in the next 5 minutes or 6 minutes also, it's going to make a big, big difference to that person. So say that, I can understand it's been a difficult time for you to come here and speak about your problems. It's okay, even if you don't want to discuss the most detail of all the problems, you can always come next time and talk to me. But today, would you like to, have you come for something very important? And then you can go about your general questions about sleep, about appetite, and then see if the patient warms up and starts talking. So you can give them that much of time.
Madam,
Sometimes patients start crying. Yeah.
One additional point, particularly in psychiatry, especially when adolescents come.
Yes.
Usually it's the family who has brought them. It's always a good idea to call the adolescent in first before calling the family.
Yes.
Because initially in my career I didn't do it. And then by the time comes, he has got an attitude that this person is not listening to me. He is listening to my parents. So now I make it a point actually that I'm trying to help you, not your family. Because they usually have this authority kind of thing that if you're going to listen to my parents, I'm not going to talk to you at all. Do whatever you want. So that's one very thing that he may actually, or she may not want to talk to you, but if you do them that courtesy, they're likely to be more open to other things.
Absolutely. And sometimes we don't get that connect with the patient on the first interview. It's okay. Don't feel that, don't feel discouraged as a doctor. Even after 20 years of practice, there's so many times when I don't form a connect with the patient at the first interview. We usually give them time. We say that, okay, I don't think you've discussed everything with me today. I'm sure you're feeling very uncomfortable. I think we can discuss it next time whenever you come, or you can write down your problems even if you don't want to express it verbally to me. So get across to them. Think from their point of view what is inhibiting them from talking to you. Again, don't try to force things down them. I'm sure you all don't experience it in other pathies, but in our branch it is very, very common. Sometimes they break down in front of you, they start crying. What do you all do?
I give them a glass of water.
Very good, yeah. Yes, exactly. Yeah. So just try to distract and let the patient cry. Okay, you don't have to say, oh, don't cry, or control yourself and things like that. You just say that, I can understand you're going through a difficult patch or a difficult time. Offer them a glass of water. If they continue still crying, say that, have you had something for lunch today or whatever. Try distracting and then get back to your normal interviewing, whatever you feel like doing. So put the patient at ease. Some patients may be nervous, so begin with a general non-medical inquiry. Pay attention to both the verbal and non-verbal cues from the patient. Sometimes you come to know that whatever patient is telling you is not the reality from the non-verbal, their body language. Okay, so they may say that I'm feeling absolutely comfortable when you're actually seeing a lot of distress on their face. And you can point it out to them that, I'm seeing a lot of distress in you. However, if you wish to talk about it, I'm there. And, if they are fine about talking, and just let them go ahead with it. Physicians should also be alert about their own non-verbal cues. Like I said, looking into the phone, not looking at the patient, okay, trying to answer so many phone calls or reading WhatsApp messages when the patient is sitting in front of us. You could, even if it's an important call or whatever, you can ask the patient, I'm sorry, I need to take this call, and take it. Put it down and then continue with your work. Always provide information on what the patient wants to know and promptly respond to the patient's reaction. So, we don't have to keep giving each and every information to the patient. Sometimes, patients come to us, they want a particular information about that diagnosis or that treatment process. We don't have to give them everything. You ask them what they know about the particular situation, and then you ask them what all would you want to know. There are problems in your diagnosis, there are problems in your treatment process. What should I talk about first? And then get back to them and start talking to them whatever they desire to know rather than anything else. Discuss the nature, course and prognosis, both short-term and long-term of the disease, treatment options available and necessity of investigations. Now all these things, okay, we call it as a part of our psychoeducation. All these things don't have to be done at one session. Most of the time, we think that the doctor has come to us, the patient has come to us and we've told them everything. We've given them all the information possible. But what happens is that the first time when you diagnose, the patient hasn't come with that state of mind to absorb everything that you're telling him. So always find out what the patient wants to know. And whatever you have told, ask the patient to, rephrase it for you so that you've understood what the patient is telling you. And then you can carry it henceforward in the second or the third session. Don't try to put across everything in a single session. It becomes too overloading for the patient. Discuss in detail regarding the necessity and feasibility of expensive investigations and drugs and their effect on the main course. So especially about the expensive bit of things, always discuss with them later on, otherwise they'll tell you that, doctor, you never told me that it's going to be so expensive. And involve the patient in decision making. Like I said, let us not have a paternalistic attitude. Even if he's choosing the worst of options, you can all do is, just explain the pros and cons of that situation. You cannot tell them that, this is the best option and you need to follow it unless the patient just surrenders himself to you and says that, doctor, go ahead and do whatever you wish to do with me. In that case also you need to tell about the pros and cons. Put additional efforts in motivating patients regarding adherence and lifestyle modification. I think you were just talking about the contemplation, pre-contemplation cycle. I'll just come to it and we'll talk about motivation over there, which is a big thing, especially with chronic disorders like diabetes and obesity. Always comprehend details in simple language. Don't use medical jargons with these patients. Communicating with attenders, this becomes a problem, especially when patients are either pediatric or geriatric who cannot understand, how to take their own course of their decision making is not proper. So, or they have patients who are admitted in the ICU. and then you have to counsel these patients. The attenders, it gets a little difficult because all these situations are a little tricky situations and you have to handle it with care. So most of the attenders, they surf the internet and they come to you. So they already Google doctors before they reach you. Let us not get irritated with them, even when we go and buy, say, a tile for a house, don't we go and investigate everywhere and then go? So it's okay, it's fine, they're trying to gather information about their condition and, what are the likely possibilities and the diagnosis and treatment. It's fine, you can just tell them what is right or wrong about it, no need to get angry about it. Always explain the dynamic nature of disease. So you can tell them that, your patient is looking stable as of now, but there are chances that, so like I said, don't give false hopes. So, tell them probabilities in numbers. This percent of people, go in for this kind of a problem. So out of 100 people, maybe 5 of them will have, a deterioration in condition. So, we may expect that. So that tomorrow, if he actually deteriorates, you can tell them that, I had told you about that 5% and, this is what has happened to your relative. Second opinion should be sought very, very proactively, because this will help in increasing your patient's confidence and their relatives' confidence. There are 2 kinds of patients I refer to NIMHANS. One is the kind whom I really feel that they require long-term stay and they require second opinion and diagnostic assessment and everything. And then there's the other kind who clearly show a lack of trust, a trust deficit with me. So, those patients also should be referred again to somewhere else just to get that, trust back on you. They want to come back, that's fine. If they don't want also, it's okay. But always never hesitate to get a second opinion in any of the cases. In fact, you sound more transparent to your patients rather than, telling them, no, I think this diagnosis, this treatment is fine. Never express shock. So, the more shocking details also if a patient is telling you, even if you're shocked inside your head, don't express it out at least, okay? So, the patient has come to you with that problem, so that problem is huge, and he's come with the expectation that I've come to a place where this problem is going to be sorted out for me. If you are expressing shock, then how is it that the patient would feel at that particular point of time? Try to convince that all efforts are being made to bring the situation under control. Consent taking is very important part of any counseling. So even if you're doing a dietary counseling or anything else, I think for all of us, consent taking is a very, very important part. If the patient is not okay to give consent, like a geriatric patient who has some cognitive deficits, or if it's a pediatric patient, so the close attender, whoever is required, but take a consent every time you're doing any kind of intervention. And intervention, I don't mean only surgeries or scopy or things like that. Your counseling, dietary counseling, anything is included in that. Never talk low about your colleagues or scold the residents, because these are people who are actually going to take care of the patient behind you. So, never scold them in front of other people. Courtesy should be displayed to all the staffs, including the nursing staff, the paramedical staff, and the supporting staff. So even if it's your housekeeping staff, you should display some amount of courtesy to everyone in general. Appreciation and positive criticism should be done. Okay. Now, what are these difficult patients that I just will like to go down 1, 2, 3, 4. Who are these dependent patients? Any idea?
You make a lot of calls, constantly seeking assistance.
Yes. So they would want, your approval for everything. Okay, so can I take a cup of coffee in the morning? Can I take a cup of coffee in the evening? All silly kind of things. So you get calls in the middle of your OPD that I'm having constipation for the past 1 day, and for even the simplest of things, or for even the simplest of decision making, even in their personal life, sometimes they start depending on you. So these are in our lingo we call it as a lot of transference and counter transference that goes on. But for a general physician also, these kind of dependent patients become a big headache. So maintain a professional demeanor with a well-established boundary. So you can just tell the patient that this is all that I can help you out. If you want help in these kind of spheres, I don't think I'm the right person to get in touch with. Involving the patient in decision making is also very helpful. So such a patient will probably tell you that doctor, do whatever is best for me, or whatever you think is right for me. But please tell, like I said, the pros and cons should be discussed with the patient, and then only, the decision should be made, making him feel that he has taken the decision and not you in his stead. Then there are these demanding patients. You must have come across them. Anyone? How do they behave? Very entitled.
Yes.
Huh? They want to come, they don't want to wait outside your OPD, they want to be sent in first, they want you to attend all the calls possible, they want the appointment that day, they just want it that day. It's not that, they'll postpone it for tomorrow, they're the ones who create the maximum ruckus in your reception area, right? So how do you deal with them? I think this judgmental approach that we already have against them should be avoided, because they are the guys who have that kind of a, personality, and they come to you. They don't probably think about things from your angle or from the other patient's angle. Again, with them, you have to establish some kind of boundaries. So, if on the first occasion such a patient has behaved in an abnormal manner outside your reception, when he comes inside, you can just tell them that, next time, I think you better take an appointment earlier, because my OPD has a lot of patients waiting, and I can't let you in like I let you in today or whatever. But by even letting them in on the first occasion, it's like a signal that you can come in next time. So always, let them know, and then you can always let them wait for a while before you call them inside. So let them wait. Be clear in your communication pattern. No, there's no need to show anger on them. Then there are these manipulative patients. Okay. Anyone come across them? This set of them? How do they behave? Like with us, so they'll come. It's like, please call up my mother and father and tell them that I don't want to do this course. Or, don't tell them, but I am telling you. Okay, see, confidential.
Commonest is asking for a medical certificate.
Yes, to avoid work. Okay, so all these things are things which, we have to keep in mind, and again, very, very clear.
Diabetes patient get false readings. They manipulate the readings.
Yes.
Or as the husband comes, says, don't tell my wife I had drink alcohol. I've told you.
That is confidentiality. That you have to maintain. So, yeah.
Two difficult situations, especially with our social norms, especially young females who are having some disease before marriage, and they are now going to get married, and that times it becomes a very difficult situation they put us in, that the parents don't want to declare or disclose any disease to the future in-laws, and then that becomes a really difficult situation, whether to tell truth or whether to hide things and talk to them. They sometimes get the in-laws also along with them for the discussion. So
see, we have to maintain a confidentiality of patients, but apart from that, you cannot tell lies to the in-laws saying that she's just had the onset of illness. So you tell the patient and the parents earlier on, saying that, see, if you bring them along, I will not tell lies. Okay, so I have to tell, so either you handle it at your level, or I don't talk about the onset of illness at all whenever you come with your in-laws. But I don't think you get, along with them and start saying that, the illness just started off.
No, I have a take care. A lot of my patients, what they do is, once they get married, they open a new file altogether. Okay, and then they would come and tell my receptionist that please inform doctor that I'm an old patient, but the doctor should behave as if I'm coming to the doctor for the first time. It's very, very common. Hypothyroid patients, diabetic patients, very, very common.
It's very common.
And hypogonadism. In endocrinology, we have a big problem with hypogonadism. So, they will come and I remember there's a fight outside my OPD between the two parties. And it's such a problem it is. It's a big problem.
Ma'am, I have one question. How to deal with when they try to bargain with you for your fees? Like, that doctor is taking the same treatment you are offering. That is what they compare.
Put a board outside.
Yes. So another physio is taking this much of amount of fees. And you are taking. So how to deal with that?
And not negotiable.
I don't know.
See, if you can actually give them a concession because of their socioeconomic strata, okay, do it without informing the other patients. So this is like demanding. Bargaining.
Yes, with the higher strata, not more.
अरे mic switch कर.
So the lower strata is ready to pay.
Yes.
The higher strata, I mean, they are well to do, and then they come, ma'am, थोड़ा bargain नहीं हो सकता क्या?
Poverty is in the mind, so please.
Poverty.
Wealth has nothing to do with
Poverty
the
is in the mind.
So I have seen the Choppadpatti patient paying whole of my fees, and I have seen the most top-end executive not bargaining with my receptionist first. So I think that is a mentality.
Yeah,
You can't really change that.
But then how to deal with
I
that?
have a solution to this problem.
Well,
What
I
you
see
should,
that a lot.
no, what you should do is, if you have a reception, first thing is, as doctors, I think we should not be collecting fees directly from patients in our OPD. That's the first thing you should do. There should be a receptionist who should do it. And you should clearly put the charges on the board behind receptionist. First visit, whatever, 800, 1000, 700, whatever main things you do, so that there is no question of negotiating. The charges are there. When a patient walks into the reception area, he sees the charges and then he wants to meet the doctor. That's how it is. In fact, when you start collecting money on as a doctor, then the problem is all this bargaining comes. And it's very, very difficult. We doctors have a big problem, talking about money directly to patients. They will say that I don't have, like for example, I remember patients telling, I don't have money to pay my bus fare. Can you give me 50 rupees? Can you give me 100 rupees back? Those kind of things also. So, we have to do it. It's like that.
आप इतना benevolent दिखते हो कि बराबर है.
Just problem
See,
here.
for that ना, मेरे ख्याल से अमित सर इतने benevolent दिखते हैं. Because of your benevolent appearance, people make this demand. Because of the.
Nobody asked me.
Because of.
Siphons and beard and everything.
While as the way I go to the hospital, the patient feel कि यार ये कितना है गरीब पे यार इसके जूते फटे हुए हैं, इसके कपड़े पुराने हैं, इसकी पुरानी गाड़ी है,
Actually, this is like, I have a different problem. I do not have it. All my consultations are online, and patients are referred by doctors or they come directly. So there is no receptionist or
It should be prepaid.
yeah.
It has to be
And
prepaid.
like there will be always discussion. Okay, someone else is charging like 1,000 rupees. Why you are charging 3,500 rupees?
Have you all
The
ever?
best part is my receptionist is here. She will just show the notice board. Whenever the patient is there will be a first fee and second fee. So she doesn't talk. So
Have you all heard of a concept called assertiveness?
yes.
I think all of us have to learn that. Okay, you don't have to be submissive and sound sorry about the fact that okay, I'm charging this much or whatever your charges is fine. The other way is being rude to them. No, who are you to ask me? You can just tell them that these are my charges. If you're fine with it, please go ahead. Otherwise, there are many other options apart from me, and it's okay. Earlier part of our career, all of us are bothered about the fact that whether this patient will come back to me or not. It all happens. By the time we reach our stage, I think we all get used to it, and we know whether or not they are going to come back. So it's absolutely yeah.
And how do you handle people when you don't require any medication, and even your colleagues also don't have to give them any medication, but they say you only spoke to me. There's no medication for this. I don't want to practice at home.
This is my time that you're paying for.
That sounds very rude.
No, you say that this is a form of treatment that I have started you on. Please label your treatment. Okay, so whether it's therapy or counseling or whatever you call it, say that one therapy session will last for 45 minutes. It's going to cost you 1,000 rupees, 1,200 or whatever. But just let them know before starting. Don't do it later.
Especially when like assessment session, you take long.
Yes.
And the people feel that you only ask me questions, you only ask me to take something, and they are very reluctant to pay.
So you should tell them beforehand itself. All this explanation has to be given to the patient before you start the assessment or the therapy itself, rather than after you've seen the patient. Yeah.
इसका एक सादा एग्जांपल है कि अगर पंक्चर वाले के पास आप जाते हो और पंक्चर चेक करता है, वो पंक्चर नहीं भी रहा तो भी ही चार्जेस बस सेमच पैसे घेतात. पंक्चर दुरुस्त करण्याचे वेगळे घेतात. But it is the simple thing. त्याच्यामध्ये काही वरी करायचं काम नाही की मी तुम्हाला काही दिलंच पाहिजे असं काही गरजेचं नाही. दिस इज अ कॉस्टली, दिस इज टाइम वेल इन्व्हेस्टिंग.
Plumber, electrician, everybody comes.
No, actually, I have found that giving a nice smile and a pause usually puts the patient on a back foot. Once they are just prodding, your response, what you will do. क्यों इतना चार्ज किया सर, बात किया, then I just smile. I don't say anything, and then I say that, okay, what is your opinion? ज़्यादा लगता है कि आपको? हाँ, थोड़ा कम करो ना. Then I tell them नहीं हो सकता सर. आप ऐसा करो, अगले बार सोच के आओ, इस बार देख के जाओ आइटम. Then it is their opinion whether they want to come back or not. But I tell them अगले बार सोच के आओ कि थोड़ा ऐसा है इधर करके, बाहर रेट कार्ड लगाया है, पर इस बार तो देना पड़ेगा. दिए बिना मत जाओ आइटम. I also ask them कैसे देंगे, गूगल पे करेंगे, कैश देंगे, सब बता के जाओ. I do that. I mean, I differ from you because actually, they give help to the receptionist. Then we have to start treating the receptionist also. So I usually support them very strongly. I support the receptionist strongly. I tell the receptionist to tell them that even about scheduling and all, adjust करो ना, मैडम को बोलो ना, मैडम ये करती है वो करती है. So I tell the receptionist, you tell them, ठीक है मैं मैडम को बताती हूँ, फिर वो आपको बताएंगे कि क्या करना है इसमें. Then see these are all their internal conflicts, and they also have a good cop bad cop. They want to appear very good to you, but they want to give help to your. So whatever things they have against you or against the system or against the authority, they project it on the receptionist. The receptionists don't deserve this behavior. They are the backbone of our system. So I give them a pause. Most of them, after I smile, they say, "Sorry, madam, आपको पूछा है." ऐसे ही पूछा हमने.
Very keenly. Yeah, is our master. I think my patients are more scared of her than their officer. I'm so glad that she's listening.
Yeah, so they most of them. That's why in practice, I don't know how it is in Pune, but in Bombay, most of the receptionists are called Vasuli Pais.
Okay, so and the other thing that I would want to stress on is about the confidentiality aspect. So never break your patient's confidentiality. Even if another relative who's working in your own hospital wants to come and find out about the patient, never talk about your patient. Just you can be polite and say that I don't wish to talk about my patient in his or her absence. It's okay if you can bring him along and talk. So if the intention is clear, then bring the patient along. If there's some other intention attached to it, then obviously they'll never come back to you. Now, this is something important that I would want to speak on today before we wind up this session is motivation enhancement therapy. Now, you all see a lot of chronic cases, right? Diabetes, obesity, and everything else. In our branch in psychiatry, this was started actually for substance use. Okay, so motivation enhancement was usually done as a therapy proper for substance use disorders. So take an example of a patient who has alcohol dependence syndrome. A patient who's drinking every day, day in and day out, and he has, no such thing coming in his mind that he needs to give up alcohol. How do you nudge the patient, or how do you start pushing the patient and tell him that, okay, it's high time you need to give up alcohol? Same thing applies to obesity, same thing applies to, diabetes in patients who are not doing too well and don't want to take care of themselves. How do you nudge these patients? Anything? So, like I said, it was initially done for the addiction disorders, but it's useful in any chronic illness where we see a lot of remissions and relapses. This is needed to motivate patients to understand, to start or to continue their treatment both. It used to be used also to reduce the risk in behaviors of HIV patients. Very helpful in eating disorders and, like I said, obesity or any other chronic ailments. And it also helps out in non-compliant patients. So this is the cycle of motivation enhancement. The first thing, what we call, is it visible? So it's called pre-contemplation. So this is the stage wherein the patient is obese, but he or she does not want to do anything about their obesity, right? So that is one stage. The next stage comes of contemplation, wherein, no, I think I should lose some weight. How does that phase come from pre-contemplation to contemplation? By information, yes. Education. Sometimes, a negative comment from someone. You're looking so fat. Okay, so those kind of negative comments also. Sometimes a health-related disaster happens. An obese patient lands up with MI. Okay, and then he starts thinking that I should give up my weight, or a doctor tells him at some checkup in seeing the usual annual checkups and says that you have pre-diabetes, you need to start losing weight. So these are the instances wherein pre-contemplation can be changed into contemplation. So usually these are the patients that can be helped out only with education. So you need to tell them what are the advantages, disadvantages of going into contemplating at least losing your weight. Now what happens at contemplation phase? There's a lot of ambivalence in the patient. I should not, right? So, who's going to take up so much of problems, going to a dietitian, exercising, getting up at 5 in the morning with all my work, I don't think I can do it. So there's a part of you which keeps telling you that, I don't want to do it because of these factors, but there's a part of you which makes you want to, give up your weight and do things actively to start losing weight. So how do you push them? Suppose a patient comes to you at this stage in the contemplation phase, how do you push them into action?
Prioritizing, we ask them to prioritize. What are the barriers? क्या आपको रोक रहा है? क्या आपको करवा रहा है?
Yes.
So, one Dr. Phadke mentioned yesterday 3 things: jaw therapy, nudge therapy, and push therapy. Like the strong why we use, why you want to do a patient to contact.
Yeah. No, but this guy may say that no, I don't want to go also. At times, he can easily push himself back into a phase wherein he says, I don't want to lose weight. You're telling me so much, I don't want to. Create a discrepancy between what he wants to be and what he's doing right now. Kind of phrases that you need to use with these patients are very important. Putting them things, very directly, they get just put off. Very easy for them to again go back to this pre-contemplation phase. Okay, our aim is to push them from this contemplation phase into the action phase. So let us not be rude to them, let us not sound very authoritarian. So how are you going about doing it, or what are your plans to then do what you want to do or what you want to achieve. So that is what that pushes them from this contemplation phase to the action phase. Sometimes again it may be a health emergency, a family emergency that actually pushes them into this stage of contemplation to action. But many a times it's the therapies or the doctors who actually can push them into it. From the action phase, so they've taken some action, they've started following whatever routine that you have told them to, and after that they go into the maintenance phase. That is, they've lost some amount of weight and they're maintaining with it. But how many of them don't have a relapse? Many of them, right? Right?
Yes.
So what is it that makes them go from the maintenance phase into a relapse? Like in alcohol, we say that the patient has stopped alcohol for the past 6 months or a year, and then there is a party wherein a friend says that my son is getting engaged, why don't you come tonight, we're going out. So this guy thinks, 1 year I've stopped alcohol, why can't I go and try today? And that one doesn't stop with one. Yeah, trigger.
Going from contemplation to action, it can be done with extrinsic motivation, but for staying in maintenance requires intrinsic motivation. And because of that issue, they will always end up in relapse because we are not going to be there
all the time. Yes. So here is where we realize the importance of staying in the maintenance phase, or not letting the lapse become a relapse. So once he has lapsed, once he's gone and eaten too much or binged, okay, don't let it become a feature in daily life. Don't let it get into a relapse. We need to both address the external and the intrinsic factors, like you said. Okay, so the external factors are like just controlling the stimulus outside, not allowing them, we can't say allowing them, but letting them be more aware of their external situations and telling them not to overindulge in eating, or if they have overindulged, to just come back the next day. Internal factors are the ones that actually require a lot of therapy, stress management, okay, problem solving skills. Those are the things which actually help out person in the long run, and that is why I want to pay, for you all to be paying a little more attention to this phase of your therapies, that is, preventing the lapse from becoming a relapse totally. Because, again, they relapse, they go back again to that usual weight of 120 kilos, which they had brought down to 110 or, 100 kgs or whatever. And then again, they go into this pre-contemplation phase. A lot of damage is again done to their health, and then henceforward. So this is a cycle which is a very important cycle, I feel, in all chronic ailments, and we can help out our patients a lot to improve on their compliance and improve their health altogether. So the goals of motivation enhancement is to help individuals overcome their ambivalence or resistance to behavior change. So when they are in that ambivalent mood, like I said, create a discrepancy of what you are and where you want to be, and that is how they get into then the phase of action. Increase motivation by raising awareness of the problem. So education, like Vaishali said, adjusting any self-defeating thoughts that, oh, I can't do it, or, I tried last time, maybe 5 days I went out for a walk, the 6th day again I slept. And increasing confidence in one's ability to change the particular situation. So express empathy with these patients. Like I said, develop the discrepancy between what their actual state is and what they want to be, their desired state. Avoid argumentation with these patients. Okay, don't get into arguments with them. They'll run out. They're already in that ambivalent phase where it's very easy for them to go back and say that I don't want to do anything about my weight. So avoid arguments because they could result in defensiveness and resistance. Roll with resistance. So even if they're saying that, doctor, whatever you're saying sounds okay, but I don't wish to change. Okay, so you don't have to force yourself on the patient. Just say that, okay, it's fine if you don't want to change. Whenever you think about it, okay, I'm always there, or, whenever you need help, I'm there. So don't close the chapter for these patients. In fact, these are the patients, if he's come once to your clinic, means there is some idea in his mind to change. So respect that idea and let him have an open door for you wherein he can come back and again consult you. Support self-efficacy, make these clients aware of their ability to successfully undertake the actions that are needed for the change. So you have to support that. That we'll be talking in the management of obesity as well. The treatment options in motivation enhancement therapy are not prescribed. So these patients should not be told as to, you have to do this or you have to do that. They are elicited from the individual. Okay, so if an obese patient comes and you've already given the education bit and said that, okay, this is what we usually follow in our usual format, and then you ask him that, okay, so what all do you think you need to do? So get the treatment options from the patient rather than you giving any kind of treatment options to the patient. So the plan outlines desired changes, the reasons that the changes are desired, and the steps that the individual will take. And your interaction with them should be non-confrontational and non-judgmental totally, okay? If Vani wants to do this, or if any of the participants want to do this. This is a case of a 32-year, we'll just take up one or anyone. A 32-year-old male working in the IT industry, married 8 months back, underwent a general medical checkup as an annual requirement of the company. He is diagnosed with diabetes mellitus for the first time. How will you break the news if this patient comes to you? Any of you, 2 people, any of you can come here and do the role play if Vani wants to assist.
I'll be the IT professional. You be the bad guy first.
Any of you would want to take it up?
So you only yeah, before and after. You be the doctor.
Okay, so what's the way in which it should not be done? That's the first role play. Yeah, Mr. Kumar, come. I just went through your reports. How old are you now? Yeah, I've seen your reports already over there. You have diabetes. I think you need to take care of yourself. How come you got it at such a young age? You've not been walking, you've not been taking care of diet and all? You have family history? So then why you should have taken care earlier, no? Why didn't you get your checkup done earlier, last year and all that?
Doctor, I had to go abroad and it was
What?
very easy.
What is
I
this?
got married.
See now you're married also. Oh my God, how will you handle your life? Okay, so these are the ways in which and believe me, these things actually happen because patients come back and tell us that this doctor was so insensitive to be talking to us in this way. How can you do it better? Can two of you come and tell? Any two? I would want.
I want to act like the bad doctor.
Yeah. Bad doctor, now you have to be the good doctor.
No, it happened with me actually. I was just in second MBBS and my dad was playing a match of tennis, and it was a Sunday morning and I was waiting for my dad to come back from his match of tennis, and my mom had prepared lovely idli sambar and that full aroma was in my house, and we are waiting. It's past 9 o'clock, it's 9:30, he would come back by 9, and when he came, somebody knocked at the door. When I ran to the door, there was his partner with white dress, and holding my dad's racket. So I said, "Where's my dad?" So he said, "Daddy's in the dispensary." So I ran to the dispensary. The dispensary was down only, and the doctor there, she was giving him. There was a man there who was lying on the bed, curled up in a fetal position, holding his heart in his hand, and he was having pain written on his face, on his forehead, on his inside his eyes, and the doctor was giving him carminative. She said, "मैंने ना इसको 6 बार दिया है वो pink color का वो solution." And he couldn't even talk. My dad couldn't even talk. I started crying immediately. I was the second MBBS. My mind was with the complications of myocardial infarction, and I rushed him to the doctor there and to the big hospital. And there, when they did the ECG, my dad is still lying there, and this doctor giving me a lecture and telling this, what is the lifestyle? And my dad is an athlete. My dad plays badminton. He teaches badminton, and he teaches everybody about fitness. And he goes on and on and on. I cannot follow it because when he started talking about this, I wanted to jump and say, he started giving a lecture on lifestyle. So the man with pain there, you got to rush him to the ICU, and then he's giving us this lecture that you have a very severe myocardial infarction, lateral, lateral anterior descending artery, the big artery is gone completely. I don't know what's going to happen, and you better make your lifestyle. But not even asking questions about who you are, what is your lifestyle like. That's a very wrong way of doing it. Thank you so much.
Do it in the right way now.
You're the doctor?
No.
Same patient.
Good doctor.
Good morning, doctor. These are my reports.
Hi, Vani. How are you today?
Thank you, doctor. I'm feeling better now.
Have you seen your reports?
No, doctor. I was too scared to see the reports.
Not to worry. You have a little bit of sugar in your report, but you don't look that kind of a sugar patient. You must be just early stages. Fasting is 139 and postprandial is 157. And your HbA1c is just about 7 or 6.9. So it's all right. So are you worried?
Yes, doctor.
Why? Do you have any patients in your family who have diabetes?
Yes, doctor. My auntie, I'm only 32 years old, and I'm thinking that I will not be able to have party or any of those things.
Don't worry, you can have all your parties in the world. First, we will talk about why you got this problem. We have to think about it. What has been troubling you for so many days? Are you under some kind of stress? You have any other family history of diabetes in the family?
Yes.
Mommy, papa?
Both.
Both are having. So that could be one of the reasons, that you have inherited it. But there may be some other reasons, What else are you doing in your life? What do you do? What professionally?
I'm a computer engineer, and my work involves sleeping during the day and starting the work after 2 p.m. And I work till early morning. And I also have to travel abroad, both on the east and west.
So Vani, there we have an answer. You've answered it yourself. You're telling us you have a lifestyle which has to start in the night, and in the daytime you're doing something else. So you're not getting enough sleep. The lifestyle is very different. So you're sitting in a sedentary position for a very long time.
I sleep from 12 to 10 in the morning.
Okay. But what is happening is during the daytime maybe you're not getting enough activity. And
I go to the gym, doctor, when I pay.
Okay, not to worry. You are doing the gym and you're sleeping well in the night. You're doing everything. Let's sit down. Let's talk to each other. Let us see how we can help you. All of us are there to help you, and we will go ahead and we will help you with your lifestyle and everything. Don't worry.
Okay, doctor.
I can't handle this much. There's a patient. She does gym. She sleeps well. She does everything. There's nothing for me to do.
All patients are ideal.
Arti is making life difficult for everyone.
This is how patients respond. That's my. And that is why we all see that. That is what I feel. One second. I feel is a lot of communication is bi-directional. It is not only that we are responding to the patient. Sometimes patients also provoke us, and they are hard at work provoking us. It is our agenda that we have to treat the patient, educate the patient, be nice to the patient, take money from the patient. We have so many agendas. Patient has single agenda. It is to make this interaction as per whatever their conflicts are. Either they want to reject authority, or they want to project rebellion, or they want to act as a consumer and get maximum from you.
Yes.
They come with one agenda. Or they want to test you. So if they are from IIT, typically, they know everything. And that is a real challenge.
So, what I of IIT
Actually, I want to share with you.
Okay, I want to share with you long-term consequences of how doctor communicate with you based on my own experience.
Dr. Shangi has to leave, so I think we can take these experiences after the lectures.
It's miscommunication, how it affects. So when I was 18, because of my health issues, my mom took me to gynecologist, and I was diagnosed with PCOD at that time. And the gynecologist, how she communicated with my mom, that possibility of she having baby is very less. You have to get her married as soon as possible. और मेरे माँ के दिमाग में वो बैठ गया. She didn't allow me to take my MD entrance exam as well because I had to get married first. So as a doctor, you have to think, before you speak. And I have a daughter, I conceived within 1 year, so that was
The communication skill, I think, is a big problem. But I think what has helped me in my life, for leading a heavy practice, is that after the 20th patient, I'm fatigued. I don't want to see any more patients. And I feel that I should hunt everybody out now. It's enough for me. But at the 21st patient, my mind, again, coming to mindfulness, it tells me that nobody comes to you out of pleasure. So everybody comes to you out of pain. Tell me anybody who's coming without a pain to you. In a hotel, they would go with pleasure. In a theatre, they would go with pleasure. So a person who is already in pain, if you're going to incite more pain, that pain is very hurting. It's very bad. So that keeps me seeing the 50th patient also. So the 20 to 50th patient, I'm just thinking of this feeling. That this person has come to me not to see me, to get his pain relief. So it's my duty to help that person the way I can. Second thing which has helped me is, I never think of what the patient has come with an expectation from me. I give my job. If this was the patient who comes to me with the report, I tell the patient that this thing should have been this, and now you tell me where you want me to help you. So a patient will tell me, madam, this is my lifestyle, I think my rhythm is wrong, my sleep is wrong, and it is 5 minutes that he tells me that I want you to help me with my sleep, or my diet, or my weight, or whatever. So its job has become easier for me. I can see nearly 80 to 100 patients a day without compromising their, you can say what they have come to me with, their expectations. And I think that's one of the key reasons why practitioners are big practitioners, because they have that skill and knack to pick them in the right 1 to 2 minutes. And these two feelings, I think, will always help you, that the person opposite you is in pain, he's not in happiness. So they will forget you immediately that the pain has gone. They will never see you till they have the next pain. So I don't have any grudge if they don't come to me. I see patients who come today when I've seen them in 2006. So they come back to me is my success, I feel. They feel like coming back to me after 20 years is the success that we have achieved. So I think if you carry on this feeling, then work doesn't become a burden. There are so many patients. The 80th patient will ask me, Madam, you're not so tired, you're seeing it so consistently. He expects me to give him the same attention that I give the first patient. So I think if they are selfish, we also should be. That's what I personally agree. So this is the way chronic diseases are going to increase, and I think all of us should make our priorities in practice more evident to the patient. Yes, Sonal. Sorry, Ranjan.
Just would like to add one event. Even today I remember that event. Like I was doing my internship and one of the medicine prof, we were taking a round, and that elderly lady was suffering from cardiomegaly, cardiomyopathy because of left ventricular failure. And one of my medicine prof, when we were paused just near the bed, and she was like, that elderly lady was asking what happened to me, and in such a nice way she put it across. Aji, तुझं हृदय ना खूप मोठं आहे. I was so touched and amazed by the way your heart is big. Grandmother, your heart is so big. You know, in Marathi she said, like, Aji, तुझं हृदय खूप मोठं आहे. And she was so happy. That elderly lady was so happy. And that one event, you know, even that itched my heart. Like, how we could communicate a disease in such a positive connotation to that elderly lady. Like, she was happy to know that her heart is big. You know?